It's my pleasure. It's my pleasure to join you today and discuss this very important topic. As you are aware, we have Mpox with us, and according to WHO, when you have one case in your country, actually it is taken as an epidemic, and so it's that we should know about the case. We should be prepared to be able to identify any potential cases and know what to do when we are confronted with this disease. So I'll start my presentation. Sorry. So what do we know about Mpox? Previously, it was called Monkeypox, but because of the stigma associated with the word monkey, it was changed to Mpox. Mpox is a zoonotic disease, which is caused by the Mpox virus. I need to change that. The Mpox virus is a member of the genus Orthopox virus in the family of Poxviridae. We know some of the Poxviridae that do affect human beings, and this include the orthopox virus. And Mpox is one of the orthopox viruses. Parapox virus, Mollusipox virus, which we know causes Molluscum contagiosum, and Datapox virus. The orthopox virus has several viruses that cause human disease, including vaccinia, which is what is actually used to produce the smallpox vaccine. Variola, which is the cause of smallpox, which was eradicated in the 1970s, I think 1978. Cowpox, which actually was the initial smallpox vaccine, if we remember the story of Edward Jenner in 1798. And that was the start of basically the beginning of vaccination and Mpox virus that we're going to discuss today. A bit about the virology of Mpox. It's a brick-shaped or oval-shaped virus around 200 to 250 nanometer in diameter. It's a double-stranded DNA virus. The genomics of Mpox closely resemble that of other orthopox virus. It has a highly conserved central core region, a variable region, and the tandemly repeating inverted terminal repeat regions. So looking at the virus, so as I've said, it has this central region and these variable regions. The central region is actually shared by other orthopox viruses, and what differentiates one orthopox virus from the other orthopox viruses are these variable regions. Looking at the virus life cycle, it consists of, I'll summarize it into three parts: the virus invasion stage, the replication and synthesis stage, and the virus assembly, maturation, and release stage. So the virus will attach on the cell membrane. So you have, it can either be the extracellular, it consists basically of the EV, I think it's the extracellular envelope virus, or the IMV, intracellular mature virion, which will attach to the cell wall and then enter the cell. The cell, it will be transported into the periphery of the nucleus, and this is where the virus will replicate. So we'll start by replicating the synthesis of the viral proteins, and next we'll find replication of the virus. Then this virus will be packaged, the Golgi apparatus, and then eventually the virus will be released either through active efflux or through exocytosis. As you can see, the drugs do work at different stages of the viral replicating cycle. And we are going to mention this at the end of the presentation. Characteristics of the virus. So there are two distinct virus subtypes, as you have heard. We have the Central African clade, which is prevalent in Central African Republic, Democratic Republic of Congo, and other countries around the Central African region. This virus is the one that causes more severe illness, and case fatality rates have been reported up to 11%. Looking at the West African clade, this one is found in Nigeria, Cote d'Ivoire, Liberia, and Sierra Leone. Causes less human-to-human transmission, a less severe illness, and the case fatality rate is less than clade 1, up to 6%. So this, if you remember the 2022 outbreak in Spain, which was associated with the LGBTI community, this one was caused by clade 1. And the ongoing infection in DRC Congo is actually caused by clade 2. A bit of background, it was first identified in 1958 in laboratory monkeys in Denmark. That's where the name Mpox did come about. Then in 1970, found in DRC, and it's actually endemic in this region in mammals. And when human beings interact with these mammals, then we do have varying outbreaks in this region. We also had another outbreak in 1996, and this one was also related to human-to-human transmission. Another outbreak occurred in 2003 in the United States, and this was linked to prairie dogs and a rat from Ghana. And then another outbreak in 2017, 2019, and then the 2022 outbreak that I didn't talk about. Looking at where we are right now in June, so I have statistics up to June. In June, we had 934 confirmed cases, 4 deaths, and it was reported in 26 countries. Overall, we have just sort of 100,000 confirmed cases with 208 deaths in 116 countries. Looking at the epidemic curve to date, this is up to 30th of June. You can see around June 2022 and November 2022, we had this outbreak that I was talking about, predominantly in the European region and the America region, caused by clade 2, mostly among men who have sex with men. And then there was a small break. And then right now, we are seeing an outbreak now dominantly in the African region. And if we zoom in now, looking at data from January to now, as you can see, previously it was more in the Americas and Southeast, a bit of West Pacific region and European region. It was the clade 1. But now we are seeing more and more the African clade 2, sorry. Now we are seeing more and more clade 1. The one that's the outbreak that is in DRC. I want to believe the patient was identified in Kenya also had this clade 1. Who is being affected by this disease? If you look at the demographics, so most of the data we have is from the 2022 outbreak. It predominantly involved men who have sex with men. People living with HIV constitute around 51%. A bit of healthcare workers are also involved, but if you'll find that these healthcare workers, most of them actually acquired it from the community and not from the hospital. 15% reported a travel history. Majority of the patients were infection was attributed to sexual transmission. 11% were hospitalized, and then 0.3% were ended up in ICU. 0.3% died. If we remove the men who have sex with men and just look at the other population, again, 28% were people living with HIV, 7% healthcare workers, 7% reported travel history, sexual transmission, 63%, 16% hospitalized, 1% in ICU, 4% died. I looked up at, just looking up at the recent data or what is happening in DRC from January to June, because this is more important to us as we face pretty much the same. We are more likely to get, if there's spread, it's more likely to come from DRC because of the spread from, because of the frequent travel and interactions from people who visit these areas. So in DRC, from January, we had 10,000 cases, around 1,700 laboratory confirmed, 433 deaths among the suspects, and they giving us a case fatality rate of 4%. Interestingly, more than 64% of the suspected cases and 82% of deaths among suspects in that country are among children under the age of 15 years old. So you can start seeing differences between the current epidemic in Africa as opposed to what was happening in the rest of the world. Which animals are associated with Mpox? So as you said, it is endemic. It's mostly occurs in animals. The African dormouse, the rope squirrel, the sooty mangebe monkey, the Gambian poach rat, and other species in Central Africa. And then when human beings interact with these animals, then the humans get infected, and then the human beings will now spread this disease among other human beings. So as I've said, primary infection, the infection mostly occurs when humans get in contact with the infected animals, and then primary infection now will occur from animal to humans, and then these humans will, so when we get a secondary infection from human to human, and then these humans beings, when they travel outside the endemic region, will transmit this disease to other human beings. What are the environmental and social factors that do cause this disease to infect human beings and to spread from human to human beings? We know deforestation, and a lot of it is occurring in Central Africa, civil unrest and poverty, bringing animals, especially these wild animals that have Mpox, closer to human beings. Climate change, and also importantly, cessation of smallpox vaccination, which had a protective effect against Mpox. And when it was stopped around 1980, so those of us who are born after 1980 and were not vaccinated, then you'll find that you are more at risk of acquiring the illness as opposed to those who are vaccinated against smallpox. So how is it transmitted? The most important mode of transmission is direct skin-to-skin contact. So when you get in contact with a rash or scabs from an infected person, or also contact with bodily fluids and exposure to saliva, either upper respiratory secretion, bodily fluids, and lesions in the genital or anal region can lead to transmission of the virus. Prolonged face-to-face interactions, this virus can be isolated in respiratory secretions, and prolonged extended face-to-face activities, talking, breathing, can lead to transmission. Contact with contaminated objects. So a patient with Mpox who these scabs have fallen and they contain this infected material. So if you touch the material, the fabrics or surfaces, or if you inhale any of the infected material from these infected objects, it can result in transmission. Vertical transmission has also been documented from infected mothers to their babies. And then, as I said earlier, primary infection from infected animals, either through being scratched or bitten by the animal, or when you're preparing the animal or preparing the animal products. Then the virus can enter the body through broken skin or through the mucosal surfaces, oral pharynx, ocular, genital, or through the respiratory tract. Looking at the incubation period, so around 5 to 21 days after infection is the incubation period, where patient can actually have no symptoms during this stage. And then symptomatic patients, within the first 1 to 4 days, this is when you get the febrile stage. So the patient will present with a fever, lymphadenopathy, headache, chills, sore throat, malaise, or fatigue. The rash presents anywhere from 2 weeks to 4 weeks. And then after that is the recovery stage. Factors that do influence progression of the disease and the patient at risk of severe illness. So most of the patients are asymptomatic, but children, patients who are immunodeficient, for example, HIV patients who are infected with HIV or any other form of immunodeficiency are at risk of severe illness. And also infection with the Congo Basin clade has been associated with a severe illness. People who have prior smallpox vaccination or previously infected with smallpox, this is protective. And as I've said, the Congo Basin clade is actually associated with a higher case fatality rate of around 10%. Signs and symptoms, the most prominent and the one that we know is a rash, but we do have other symptoms, especially fever, chills, swollen lymph nodes, especially the cervical lymph nodes. So this is something to look for, especially in the early stages of the illnesses, exhaustion, muscle aches, backaches, headaches, and respiratory symptoms. Not all patients will experience the same symptomatology. So some individuals may experience all, some may experience only one or few symptoms. People can also have a flu-like symptom before the rash. So right now, when many people are having a flu-like symptom, it may be difficult to differentiate between Mpox, the initial stages of Mpox, and just a normal flu. Some people actually may get a rash first before they get other symptoms, and other people may only get a rash and they may not have any other symptoms. Looking at the proportion of cases with symptoms, which symptoms are common. So as I said, any rash will affect up to 83% of the patients. Fever is the second most common symptomatology at about 58, and then a systemic rash at around 50, genital rash, especially if it's sexually transmitted, about 46%, headache. Lymphadenopathy is also pretty common. Then the rest, as I've mentioned, the fatigue, muscle aches, and so on. Looking at this rash, it actually progresses through different stages. So initially, it's a macule. So this is a flat lesion, maybe a erythematous lesion. In darker skin, it will just appear as a hyperpigmented lesion. And then day 1, day 2, it becomes a papule, and then a vesicle, which is a fluid-filled papule, and then it becomes a pustule. As you can note, it's actually umbilicated in the region, and then later on, it will form a scab, rust, and then it will heal, leaving behind a hyperpigmented skin lesion. Looking at the lesions, as you can see in this patient, is a pustular, papular vesicular pustular lesion, which can pretty much occur anywhere in the body. If you look in the face where it tends to begin, it looks like this. You can see this. Some are pustules, some are papules. It can occur in the mouth. As I've said, these are pustular lesions on the face, in the mouth, on the tongue, as you can see, also on the oropharynx. Also in the genital lesion, especially among men who have sex with men, and these lesions can also coalesce and become confluent, subsequently forming larger ulcers. And this was actually in a patient, in a HIV positive patient, who was virally suppressed with CD4 cell count of more than 500. Can also occur in the genital region in female, as you can see, the genital region around the vagina, and also actually intravaginal area. And this lady also had lesions in other parts of the body, in the arms and in the fingers. It can also, as you can see in children, it tend to have more severe illness as compared to the general population. So like this baby, it occurred all over the body, also this one. And then lastly, as you can see, the crusting face, the last picture. The lesions can also occur in the eye, and it has actually been associated with adverse outcomes, including blindness. So you can see the first the broad area, the white arrowhead, and also a rancule on the black, this black area before, around the fall of illness. In some people, actually, the only thing that you may notice is this maculopapular rash that occurs pretty much all over the body. And then in this patient, as you can see, also there was involvement of the oral pharynx. So be aware of atypical presentations, especially in immunocompromised patients, HIV-infected patients without who are not viral suppressed and who have low CD4 count. The only presentation that they may get, especially the initial stages, may be this confluent maculopapular rash. Other typical presentations, you may see few lesions or only a single lesions. Absence of skin lesions, but the patient may only present with anal pain or bleeding. You may find lesions only restricted to the genital or perianal area and do not spread to other parts of the body. Usually, the lesions are synchronous and occur at the same stage, but you may find in some patients rashes that appear at different stages of development. And then you may also find patients who may have lesions that occur before onset of fever, malaise, or any other constitutional symptoms. It's also important to be aware of other conditions that may present as smallpox. So herpes simplex virus, varicella zoster, the cause of chicken pox, molluscum contagiosum, especially in seroreactive patients, enteroviruses, which can actually cause skin rashes and fever, especially in children, measles, scabies. Secondary syphilis can also cause a rash, bacterial skin infections, medical allergies, parapox viruses, and also chancroid. So when you see a patient who presents with a rash and mpox is one of the differential, it's also important to be aware of other infections that can present in a similar way, and it's important to rule out these infections. I'm looking at just looking at 3 infections that can mimic monkeypox. So if you look at monkeypox, as I've said, a fever normally appears 1 to 3 days before the rash. Chicken, it's usually about a day or 2 before the rash, and in measles, about 3 to 5 days before the rash. The rash in mpox, as I've said, normally they are in 1 stage of development. Chickenpox, these lesions tend to be in multiple stages of the development. And also in measles, the lesions are often in multiple stages of development. The rash in mpox progresses slowly, as opposed to chickenpox and measles, where the rash progresses more rapidly. Looking at the distribution in monkeypox, more dense on the face, can also be present on the palms and sole. In chickenpox, it's more dense on the trunk, highly unlikely to present on the palms and the sole. And in measles, it starts on the face and spreads. Sometimes it can occur on the hands and on the feet. Watch out for lymphadenopathy because it's actually it's present in mpox, especially cervical lymphadenopathy. Absent in chickenpox, may be present in measles. Death up to 10%, as you have seen, especially in children and immunocompromised. Not so common in chickenpox, and it varies in measles. We've seen mpox rash. Chickenpox rash, as you said, it tends to be more vesicular, and in measles, it's more of a maculopapular rash. When it comes to diagnosis, so diagnosis, or how you diagnose and the sample you take will differ depending on the stage. So in the incubation period, really, not in terms of testing, there is no test that can really, at the moment, like identify the disease. But at the febrile stage, which is around day 1 to day 4, then here you say that tonsillar or an nasopharyngeal swab, and then subjected to PCR testing. And then in the rash stage, then you are going to get a sample from the lesion, and you are going to see how you're going to get the sample and then test it using PCR. And then you can also do antigen detection during this stage. And then recovery stage, if you want to confirm, then you can check antibodies against the mpox virus. So how do you collect a sample from the lesion? So you need to sanitize the lesion, and then you remove the roof of the lesion. Then you use a swab to brush the lesion and put it in the container, close the container, and this is what you'll submit for PCR testing. For the crust, then again, sanitize, remove the crust, and then you can collect the crust in a container, and then this is what you are going to submit for testing. For oropharyngeal testing, basically the same procedure we use to test for COVID. It's the same. You'll just take the sample the same way, and then that is what you will submit for testing. About case definition, this is a bit wordy, but we'll go through it. So who's a suspected case? So a suspect is a person who is a contact of a probable or a confirmed mpox case in the last 21 days before the onset of signs and symptoms, and who presents with any of the following: either an acute onset of fever, a headache, myalgia, back pain, profound weakness, or a person who's presenting with an explained acute skin rash, mucosal lesions, or lymphadenopathy. And then the skin rash may include single or multiple lesions in the anogenital region or elsewhere in the body. The mucosal lesions may include single or multiple oral, conjunctival, urethral, penile, vaginal, or anorectal lesions. And anorectal lesions can also manifest as anorectal inflammation. So it may only be proctitis and not just evident lesions or pain or bleeding. And for which the following common causes of acute rash or skin lesions do not fully explain the clinical picture. So these are the different, the differential diagnosis that I had earlier mentioned. So if they do not fully explain the presentation, then this is a suspect. A probable case, then pretty similar to a suspect, a patient presenting with an explained acute skin rash, mucosal lesions, or lymphadenopathy. And then the skin rash is as I have described. And one of the following has an epidemiological link, not just a contact, but an epidemiological link, a probable or confirmed case of mpox in the last 21 days before the onset of symptoms, has had multiple or casual sexual partners in the last 21 days before onset of symptoms, and then has a positive test from an virus infection. So this is a test that detects orthopox, but it's not specific for Mpox. For a confirmed case, now this is one who has a laboratory confirmed test, confirmed Mpox infection detected by unique sequencing of viral DNA, a real-time polymerase chain reaction, and sequencing. So this is very specific for Mpox and not just for the orthopox virus. Please note that a PCR on a blood specimen may be unreliable and should also not be used alone as a first-line diagnostic test. And if a blood PCR is negative and it was the only test, it's not sufficient to discard a case otherwise that meets the definition of suspected or probable. And this applies regardless of whether the blood PCR was for just for the orthopox viruses or specifically for Mpox. So basically what this says, a blood PCR test is not enough to rule out Mpox in a patient. Who is a discarded case? So this is a suspected or a probable case for which a laboratory testing of a lesion or a skin specimen or a first PCR is negative for Mpox. Retrospectively, detected probable case for which lesions testing can no longer be adequately performed, and this is where the lesions have after the crust have fallen off, and this you cannot really find a specimen for PCR testing will remain a probable case. So if somebody was suspected, and then by the time you are testing the patient, you cannot get the lesions, basically, that will remain a suspected case. A suspected or probable case should not be discarded based on a negative result from an oropharyngeal, anal or rectal swab, or from a blood test. A suspect or probable case should not be discarded based on a negative result from oropharyngeal, anal, rectal, or blood test alone. So unless you can, you have tested the crusts or the lesions, then you are not going to discard that case as a suspect or a probable case. Who's a contact? A contact is a person who has been exposed to an infected person during the infectious period, i.e., the period beginning with the onset of the index case, first symptoms, and ending when all the scabs have fallen off, and who has one or the following exposures with a probable or confirmed cases of Mpox. So either direct skin to skin or skin to mucosal physical contact, such as touching, hugging, kissing, or an intimate or sexual contact. Or if the person came in contact with contaminated materials, such as clothing, bedding, including material dislodged from bedding or surfaces during handling of laundry or cleaning of contaminated room, or prolonged face-to-face respiratory exposure in close proximity, or if there was respiratory exposure including inhalation, or eye mucosal exposure to lesion material including scrubs or scabs from an infected person. And the above also apply to a healthcare worker potentially exposed in the absence of proper use of appropriate personal protective equipment. So if you, especially for, if you are doing contact tracing or for potential contact, then you are going to use these definitions to define a contact. So if maybe you are around somebody and there was no prolonged face-to-face exposure, then that person does not meet the definition of a contact. It has to be one of these that has that I have presented. Then coming to treatment. In summary, treatment actually is mostly symptomatic. care. Antimicrobial therapy and antivirals will only be used in specific cases. So starting with antivirals, as I've said, there is no specific approved treatment for Mpox, and most people will recover within 2 to 4 weeks without need for medical treatment. Antivirals are only reserved for severe cases, and you will see who these severe cases are, including patients who require hospitalization, children under the age of 8, pregnant and breastfeeding women, people living with HIV, and those with complications. Please note that the efficacy of these antivirals was mostly from studies, either in vitro or in animals, and we do not have very good data on their use in Mpox. There are a number of antivirals. We have, the first one is tecovirimat, which you remember, it acts just after viral replication when it's being packaged before it's released. So it inhibits that phase. And it was developed for the treatment of smallpox in adults and children. And it's available in capsules or in intravenous form. Brincidofovir, which is a prodrug of cidofovir, which we have used for treatment of smallpox and also CMV in adults and pediatric patients. And also cidofovir, which has been used for treatment of CMV in people living with HIV. So this is basically a nucleoside inhibitor, and it inhibits viral replication. Trifluridine, also known as Viroptic, which is used for treatment of herpes, keratoconjunctivitis, or keratitis. It has been used for treatment of ocular orthopox virus infection. And then the vaccinia immunoglobulin intravenous, VIGIV, which can be used in severe cases and basically prevents attachment of the virus to the cell wall, and that's how it prevents an infection. Delving deep into these antiviruses, so tecovirimat, the oral drug is administered 600 milligrams every 12 hours, or you can administer it IV, 3 milligrams per kg for those who are under 35 kilograms, or 6 milligrams per kg every 12 hours. For those who are 35 kilograms and above, you can up to 120 milligrams per kg, or up to less than 120 kilograms. It's administered 200 milligrams every 12 hours. And then for those who are more than 120 kgs, 300 milligrams every 12 hours. And it must be administered over a 6-hour duration, and the treatment duration is 14 days. For brincidofovir, it's administered orally, less than 10 kilograms, administered at 6 milligrams per kg, 10 to 48 kilograms, 4 milligrams per kg, and adults more than 48 kilograms, 200 milligrams per kg. Duration, it's administered once weekly for 2 doses. That is basically on day 1 and day 8. Cidofovir, it's only available as IV at 5 milligrams per kg, administered once weekly, and it must be given with oral probenecid 2 grams 3 hours prior to each dose, and 1 gram 2 and 8 hours after completing the infusion. It must be given with at least 1 liter of normal saline over a 1 to 2 hour period before each infusion. As I said, it's administered once weekly for 2 weeks, and then every other week, so until the patient has recovered. And this is basically based on treatment for CMV retinitis, and we have borrowed that treatment to manage Mpox. Viroptic trifluridine. It may be considered in cases of Mpox conjunctivitis, and it's recommended in cases of Mpox keratitis in consultation with an ophthalmologist. In patients with corneal disease, including corneal ulcer, consider using topical lubricants and antibiotics to prevent superinfection. As I said, it can be vision-threatening complication of Mpox. What about the VIGIV? It's composed of antibodies from individuals inoculated with the smallpox vaccine. Its efficacy, it's unknown, and it can be considered in patients. It is unknown if a person with exposure to Mpox or with severe infection would benefit from it. But if it's available and the patient has severe illness, it can be considered in the context of prospective studies, basically in a study setting to see if it will be of benefit. What about complications of Mpox? And this is the reason why we need to be aware of the disease. So one, it can cause severe illness depending on the overall health status of the patient. So we can get bacterial infections of the eye, bacterial superinfections in up to 4%, or of the skin in up to 20% of the patients. It can also lead to diarrhea and vomiting, causing severe dehydration in up to 7% of the patients. It can cause abscesses. Remember, I said it can cause lymphadenopathy and leading to abscesses, leading to air obstruction, bronchopneumonia, encephalitis, and sepsis. And then long-term, you can get pockmarks, scarring, loss of pigmentation, which is not really cosmetically pleasing at all. Danger signs, what you need to be on the lookout for. It can lead to loss of vision, delirium, loss of consciousness, convulsions, respiratory distress, bleeding, inability to urinate, and also signs of sepsis. The common complications include a painful rash, proctitis and tenesmus, secondary skin infections, and pharyngitis. Less common, as I said, encephalitis, pneumonitis, keratitis, myocarditis, abscesses, secondary bacterial infections. In pregnant women, it can cause miscarriages, and it can even lead to death. How to manage these complications? So focus skin exfoliation, and it can actually affect a big proportion of the skin. So patients with heavy rash burden may develop this exfoliation, which may be very similar to severe cases of partial thickness burn, leading to significant dehydration and protein loss. So you need to estimate the percentage of the skin affected and consider treatment used for burns. Minimize insensible fluid losses and promote skin healing. Hydration and nutrition is very important. Again, consult as appropriate with surgeons, dermatologists, and wound care specialists. If there is need for debridement, especially in secondary bacterial infection, then consult surgery. And then if there's significant skin loss, there may be need for skin grafting. It can cause necrotizing soft tissue infections, and this can be caused by the virus itself or secondary bacterial infection. Suspect in a patient who develops edema, crepitus, malodorous discharge, or pain out of proportion. In these patients, you'll need to cover them with broad-spectrum antibiotics because, as I said, it may be because of the virus, but it may also be because of bacterial pathogens. So cover for the usual suspects, the staph and the strep. And because it's a surgical emergency, you need to consult the surgeons. Myositis, which is pus in the muscles, and this should be suspected in patients who have muscle tenderness. As I said, can be caused by the virus or skin flora such as staphylococci or streptococci. Such patients, you can use ultrasound to assist in the diagnosis. You need to collect blood cultures and also cultures from the muscle, especially because you're suspecting bacterial infection. It will aid in diagnosis and treatment, and then initiate broad-spectrum antibiotics, and then your surgical incision and drainage. And as I've said, send the samples for microbiology to guide antimicrobial therapy. Cervical adenopathy, which can occur up to 85% of the patients with lymphadenopathy. And if they are large and multiple, then they can cause respiratory compromise and retropharyngeal abscesses. And this may cause the patient to be at risk of dehydration because they are not eating and they are not taking fluids. And remember also, these patients may have significant skin loss, and this may just exacerbate the dehydration. Again, consult your ENT specialists, your anesthesiologists, and ID physicians to help in the management. And in severe cases, you may consider steroids just to help with the inflammation and to reduce the swelling. Ocular lesions, it's a really significant sequelae of Mpox. It can cause corneal scarring, and it can lead to vision loss. Patients may present with very nonspecific ocular symptoms as conjunctivitis. So in such patients, please examine their eyes. Consult your ophthalmologist to evaluate the eye. If there are co-infections, then manage accordingly. In children, especially malnourished, vitamin A supplement is encouraged. Good eye care, eye lubrication, using saline-soaked protective eye pads. Here, avoid steroid ointments, as it may prolong the presence of Mpox in ocular tissues. And as I mentioned earlier, trifluoridine eye drops may be used. Consider using them, and they may hasten resolution of symptoms and prevent long-term damage and scarring. Pneumonia is also one of the causes. It can be caused by the Mpox, but it can also be a secondary bacterial infection. Right now, we don't have enough data to say which is which. So manage the same way you'll manage any patient who presents with pneumonia. ARDS also patients may need oxygen, may need non-invasive ventilation or mechanical ventilation. Again, we now have a lot of experience managing patients with ARDS during the COVID pandemic. So we basically use the same management principles. And if you have access to any of the antivirals that we mentioned earlier, then you can consider using them. Severe dehydration is also one of the complications the patients may present with because of, one, skin loss, and two, they may not be able to take orally because of lesions in the mouth. Treatment, they'll need intravenous resuscitation with fluids. In children, you may consider giving intraosseous fluids. So just manage the patients the same way you'll manage any other patient with severe dehydration. Pneumonia may occur bronchopneumonia may occur in 1 to 10% of the patients, as I said. Tissue damage occur throughout the lungs, or it can just be a consolidation in one area. So it can present what people call a typical pneumonia, or in a lobar pneumonia pattern. Treatment, again, manage the same way you'll manage any patient who presents with pneumonia. So pulmonary hygiene, oxygen, empiric antibiotics as you try and figure out what is the cause. If they need bronchodilator medication, if they need ventilation support, provide as needed. Sepsis and septic shock. So this is different from severe dehydration, because dehydration, as we said, is because of loss of fluids. Sepsis and septic shock, this is dysregulated immune response to an infection. So follow the septic pathway of management. It may be caused by the virus. It may be caused by bacterial superinfection. Remember, as you said, these are patients who may have lost significant portions of their skin, and therefore bacteria may easily enter through these areas and cause bacterial superinfection. So try and identify what is the cause, manage the cause, manage these patients the same way you'll manage patients with septic shock. Encephalitis, again, in those who present with confusion, seizures, and so on, consider doing a lumbar puncture, because as much as we may assume it's Mpox, it may be something else. So get an CSF for evaluation to try and see if it's any other treatable cause. Monitor your ABCs as usual. Monitor your neurological status. If they have seizures, you need to control the seizures. If they have any other co-infections, then you need to treat these co-infections as you identify them. Don't forget nutritional considerations. As I said, the skin loss, they are going to lose fluids, they are going to lose proteins. These are also patients who will have poor intake because they are ill, they have lesions in the mouth, they may not be able to swallow, so they may need to be assisted. So if you have a nutritionist, then bring them on board and manage them accordingly. What about vaccination, right? So at the moment, mass vaccination is not required or recommended. We need to implement public health measures, use of PPEs for caregivers, good hand hygiene, isolation, and other supportive care during the infectious period. However, for select group of patients, then primary preventive vaccines and post-exposure preventive vaccines are recommended. And then for persons who are at risk, then broader use of vaccines may be justified. So who are these high-risk patients? So for high-risk individuals, then we may consider primary pre-exposure vaccinations. As we saw, this especially the 2022 pandemic disproportionately affected men who had sex with men and their partners. So these are considered high-risk individuals, and we are individuals who may be considered for primary prevention vaccination. And also healthcare workers and laboratory personnel who are dealing with, who are taking care of patients who are infected with Mpox, and also laboratory personnel and members who are also who are involved in the outbreak response. These are also high risk people who are at high risk and can be considered for primary preventive vaccination. What about post-exposure vaccination? So these are for contacts of cases. and it's recommended within 4 days of first exposure and up to 14 days in the absence of symptoms. And this is to prevent the onset of disease or to mitigate disease severity. Children, pregnant women, and immunocompromised patients may be at high risk of developing more severe disease. So in cases of limited vaccine supply, then these are the groups that need to be prioritized before the other general population is considered. Persons who have had the a 2-dose primary preventive vaccination who become exposed, they do not need to receive post-exposure preventive vaccination and should just be monitored for symptoms for 21 days. And persons who have had contact with an Mpox case after the first dose and before the second dose should receive their second dose as scheduled. You do not need to give it earlier. Which vaccines are available? So there are 3 types of vaccines. We have the non-replicating vaccine, the MVA-BN. We have the minimally replicating vaccine, the LC16. And we have the replicating vaccinia-based vaccines, the SCAM 200. So which vaccine is suitable for who? So for healthy adults, they can get any of the vaccine. So they can get the minimally replicating, non-replicating, or replicating vaccination. For individuals who are replicating or minimally replicating vaccine is contraindicated, and here we're talking about pregnant and breastfeeding women, patients who are severely immunocompromised, people living with HIV, CD4 less than 200, patients using immunosuppressive therapies, then these ones should be vaccinated using the non-replicating vaccine. For children, consider using non-replicating or the minimally replicating vaccines. Adults who are older than 50 years old, basically I'm thinking about those who are vaccinated against smallpox, that is before 1980, and who are eligible for either for preventive or post-exposure, they should be vaccinated irrespective of previous smallpox vaccination, or even if they have this visible smallpox scar. So if they are eligible, they should receive the vaccine. About the vaccine's protection, again, the level and duration of protection is currently not known. It takes approximately 2 weeks from the time of finalizing a complete series of vaccination with the non-replicating vaccine for immunity to peak. For the minimally and non-replicating vaccines, where you only get 1 dose, it's expected to occur around 4 weeks after vaccination. For the minimally for the non-replicating one, the one you are given 2 doses, then you've said 2 weeks, the other one around 4 weeks. I think the other question was, what about people who have previously been infected with Mpox? From my reading, it seems they're also well protected. And so far, there is no reported case of reinfection with Mpox. So they are pretty well protected as far as current literature is concerned. I think I will stop there and invite the next presentation. I don't know if you are going to take questions now or after the next presentation. Thank you.
Yeah, thank you, Dr. Nyukuri, for that excellent presentation. It was very, very detailed. and people are asking for slides. So the slides will be shared on the KNH, the presentation will be shared on the KNH YouTube channel. I don't know if Dr. Lois is still online. She had wanted to make a comment.
Oh. Hi, Phoebe. Yes, I'm here. Thank you.
Hi,
I know
hi.
you asked me to make a comment at the beginning, but I was having some trouble joining earlier. So thanks, Dr. Nyukuri. That was a fantastic presentation. I think it was a lot of learning for everyone. I think I just wanted to make a couple of comments. One is generally around how we handle potential outbreaks. So one of the things that we've seen time and again is that whenever there's an announcement of something that may potentially be an outbreak, often what we see is a lot of panic amongst healthcare workers. And the challenge with this panic is often patients who present with conditions other than what we are afraid of. So let's say in this case where there's been a reported case of Mpox, anyone who presents with a rash is regarded as a potential case of Mpox. And what happens is patients do not get adequate care because people are afraid. So there are certain things that you probably have gleaned from this presentation. Mpox is not necessarily the most infectious pathogen. Most of the infections and most of the spread has been reported with direct body contact. I know there are a lot of other possible routes of transmission that were discussed earlier, but for many of those, the risk of transmission is actually low. So the one that carries the highest risk of transmission is direct body contact. For that reason, it means you can safely take care of an Mpox, of a patient with Mpox if you protect yourself. It means that we shouldn't run away or fail to give patients adequate care because we are afraid of taking that patient. Many patients may die of malaria or other potentially treatable conditions because no one is taking care of them. So that's something that we have to think about every time there's a potential outbreak or some organism announced in the country. We saw this with Ebola, where people are now not even wanting to manage patients because a patient was bleeding in the hospital, even though it had nothing to do with Ebola. So we always have to remind ourselves of our duty to take care of patients.
Hello.
In every
Sorry,
condition.
Dr.
And what this means is that, yes.
Oh, sorry,
Sorry.
you had dropped off a few seconds.
Oh, I'm sorry. So I'm not sure what you had. Was it for a long time?
No, just like maybe 4 seconds.
Okay, sorry. So I maybe just in terms of how we approach patients, if you have a patient who has a potential, rash, fever, lymph nodes, and they're thinking, could there be a risk of, something that's potentially more infectious? Then one, take precautions. You want to isolate that patient. You want to protect yourself, but you want to ensure that you give that patient adequate care. That will be very important for how we take care of our patients. I think, let me just stop there because I know we are also running short of time. I think there's another presentation, so I'll stop there for now. Thank you very much.
All right, thank you so much for joining us. So I'll just introduce Sylvester. He's going to be taking us through IPC. Sylvester, welcome. We'll take questions at the end of the presentation. Okay, sorry, we'll go back to the beginning. I think we couldn't hear Sylvester.
Yeah. So we are going to talk about infection prevention and control measures on Mpox, whereby we are going to talk about the IPC measures. In the IPC measures, we're going to talk about what we need to do. We need to do standard precautions, and also we need to do transmission-based precautions. So about the pictures you're seeing there, these are just the pictures that have already been explained on how Mpox presents. So the transmission of Mpox, basically, Dr. Nyukurio talked about the primary infection and the secondary infection. Primary infection, he talked about animal to human, and the secondary infection was human to human. So when we talk about transmission, we are going to talk about the two modes of transmission, whereby the first transmission is about contact and the second one is about droplets. So how is contact? So contact is about we have two modes of contacts, or two divisions of contact, whereby we have direct contact and indirect contact. So direct contact basically is about direct contact with skin lesions of an infected person, or a person or animal. Then indirect contact is with the materials contaminated with the Mpox virus, such as BP machine calves. Then we move to droplets, where we're talking about the close contact with the respiratory tract secretions for an individual with infected Mpox. So basically, the droplet is a long period of contact with the respiratory tract secretion. Then we have the two, which is talking about both the primary infection and the secondary infection. Whereby primary infection, you have the animal to human that can occur through bites, scratches, bushmeat preparation. Then also we have the human to human. Also we have the human to human, whereby we have direct contact and indirect contact. So direct contact is close contact with the lesions and body fluids. Then also we have indirect contact with the contaminated materials such as beddings. Then we have respiratory droplets, whereby you have droplet precautions. This is what the mode of transmission is also still talking about. We have direct contact with infectious rash, scabs, or body fluids. Then respiratory secretions during prolonged face-to-face contact. Then also we have about the touching items that previously touched the infectious rash or body fluids. Then the first presentation was talking about also the pregnant mothers can spread the virus to the fetus through placenta. So infection prevention and control measures, we're going to take them into different points, where we're going to discuss about point of care risk assessment, then we do hand hygiene, then we do personal protective equipment, then patient placement, cleaning and disinfection, linen handling, waste management, then we'll finish up with body handling. So hand hygiene. Actually, research has shown that hand hygiene basically prevents up to 80% of transmission or infection. So basically, the hand hygiene is the best and the most effective and cheapest mean of infection prevention and control. The two methods of hand hygiene: washing, that is soap and running water, liquid soap and running water, whereby you do mechanically to remove bacteria and viruses. They also use ABHR, that is hand sanitizer, or you can sanitize your hand using waterless in solution that kill bacteria, viruses on the hand. So the staff handling the patients suspected or confirmed Mpox should adhere to the 5 moments of hand. So the 5 moments of hand hygiene basically we normally have before touching a patient, before a procedure, then after a procedure or body fluid exposure, then we have after touching a patient, then after The tendency with most healthcare workers is that we normally forget much. So we need just to remind ourselves on the moment of perform hand hygiene. So those are the 5 moments of hand hygiene, which are very, very important. Technique of hygiene. How do we perform hand hygiene? First of all, this is just an illustration whereby you lather soap. Then any procedure can kick on, and as long as you finish up with it. So this is just the illustration that shows the technique of hand hygiene. Then point number 2, we are going to talk about personal protective equipment, that is the PPE. The minimum PPE used personnel handling confirmed. Mpox patient should be glove, mask, and a gown of a confirmed. So basically, you come to know actually what about on the spread, and basically there is no need of panic because and do the misdiagnosis and also to handle our patients not in a right way. So basically, a mask, glove, and a gown during the patient care when the patient in the case. So all people each patient and hand hygiene performed. So basically, you realize that hand hygiene going each and every point will be having hand hygiene. Then also all PPEs should be done in the patient's room. Then all PPEs should be disposed prior to leaving. Then other precautions we still have hand hygiene, patient hand hygiene. Then skin lesions should be kept covered with a gown, a cloth sheet, or a bandage, except during session. Basically, we are covering it just to minimize the spread of infection to the objects or the instruments or equipments near the patient. Then also we must education to our patients, to the patients' relatives, and also to the patient transmission. Let's not just manage our patient without the patient knowing whatever we are managing, and also the transmission can be on the mode of transmission, because they also help in transmission mode, the transmission of the patient of the infection. Then also we have the places of patient, whereby the patient should be placed in a single room where possible. We know that most of the we don't have isolation areas. So basically, if it has an isolation area, you may place the patient in that. But if there is none, you cohort. Cohorting basically means you put all the patients with the same signs and symptoms together for management. So if you're doing a barrier nursing, you start with the patients who do not have the signs and symptoms, the well patient, the suspect patient, the last patient. So for inpatients, a dedicated patient bathroom is used, and the mode can be used if the dedicated bathroom is not available. Basically, isolation, if a patient put a patient in a single room, basically that single room should always be having and all the equipments that are required there. So visitors to those necessary the visitors should be restricted from moving in and out of the frequent move in and out of the isolation area. Then how do we do the cleaning and disinfection, which is also a very point. So our equipments, dedicated patient care equipment, dedicate a patient care equipment to a single room where possible. So if you can dedicate to a patient in a single room, please do. But if you don't have, the use of standard equipment cleaning and disinfection protocol according to your hospital is adhered to. Then disinfect all reusable equipment with hospital approved disinfectants. Different hospitals have different disinfectants, so just use the hospital approved disinfectants. What about the environmental surface? Be having touched that could have been touched, they are included in the area or the bathrooms. Then attention should be paid to frequently or high-touched surfaces such as doorknobs, nurse desk, bed rails, drip stands, ventilator machines, and monitors. High clean is the telephone, because so many people touch the telephone. It's what cleaning and disinfecting agents are sufficient for the environmental cleaning for mpox. A special disinfectant in cleaning the environment used by mpox patient. So laundry, where appropriate PPE during the collection, the point of use. But the linens and the thing used by the mpox patient into a red liner bag, because this is now the infectious, highly infectious, so you put it into a red liner bag. So where we don't have a red liner bag, you can put into a yellow liner bag or any other color is available, but ensure you label. If you put it in either yellow, purple, ensure you label that bag contains highly infectious. Then do not share the laundry as it disperses the contained infectious particles into the surrounding surfaces. This still explains the point whereby you said the lesions should be covered. To the laundry, just follow the hospital laundry protocol that you have. Healthcare waste management, whereby you have a waste segregation at the point of use, whereby here we'll be using a red liner. And you tie the liner bag in the point of use, then you do it as transportation, using the hospital under following the hospital guidelines on public health and waste management. Then you do the treatment or you do the disposal, incineration. 6 on the public health and waste management protocol. Then when transporting the mpox patient, if a patient with probable or confirmed mpox requires transportation, contact precautions should do. So any patient who is a suspect, probable or of mpox who requires transportation, just ensure that contact precautions are adhered to. The patient should be masked and lesions covered during transportation. Any need for a referral for further management of the patient, the receiving healthcare setting should be informed before the patient's arrival of the diagnosis and the need for contact precautions. Then all patients with infectious disease at the point of first contact. So basically, if you identify the patient in your area, don't move from that location to another place. Just manage that patient at that point. Basically, then finally, we're having the handling of the mpox body. I know people are asking, is it a special case? How do we handle it? No. Personnel who mpox body should wear the PPEs as recommended by the hospital protocol. The body should be prepared following the routine healthcare facility procedures for cleaning and containing body fluids. Then the body should be placed in a body bag at the point of collection. I know most hospitals do not have, it doesn't make us the need to request for body bags. We just use whatever we really have, as long as we minimize the spread of the lesions to the near. Please note that do not put the patient into 2 bags. It's just one bag, or whatever the protocol, your hospital protocol lays down. So if the body requires autopsy to be performed, autopsy. So there is no special case about mpox. So that is all about the mpox on infection prevention and control measures. Thank you.
Yeah, thank you very much, Sylvester, for those important messages. I think from there now we'll go to the Q&A. Dr. Nyukuri, I hope is still online with us. So the first
Yeah.
question, I'll direct it to you, Dr. Nyukuri. I think you had covered it in your presentation to some extent. So they're asking, where can suspect cases undergo lab testing? And what is the approved test kit in Kenya? Maybe that's a bit detailed. Dr. Nyukuri, can you hear me?
Yes, I can hear you. Can you hear me? No? Can you hear me?
Yes, I can hear you.
Okay. As far as testing is concerned, I think it can be done at the National Public Health Laboratory. I'm not sure if KEMRI can do that, but I think that's something we can look into. In terms of test kit, I think I've already presented the how the samples can be collected, and we'll share the slides. And the testing is a PCR test. It's basically the same test that not similar test to the one we are using to test for COVID. Just amplifying the DNA, and then you're able to identify the virus.
Okay, thank you. So maybe this is to Sylvester. Someone is asking, what are the main control measures? It's I think you've covered them in the presentation. Maybe just to highlight again for healthcare workers.
So basically, the main control measures for healthcare workers is just use of PPEs. During you realize that I talked about point area, you just do the right assessment. And always, we are always informed that you should not attend to any patient without a glove and also a mask. Those are the major main control measures. Then also another control measure, if you find, please manage the case at the point of identified contact, not move the case to different areas.
Thank you. Now, the next question, they're asking about the drugs. There are those drugs that you mentioned in your presentation and the vaccines. So someone is asking, are these drugs and or vaccines readily available in our health facilities? From your experience, Dr. Nyukuri.
Well, that's a hard question. I don't think the vaccines are easily available. Remember, these vaccines were developed to target smallpox, and we stopped mass smallpox vaccination in the 1980s. So I think if there is need to source for them, then that's a whole other process. But I doubt if they are easily available in our health centers at the moment. But as the epidemic progresses, I think I'm pretty sure the ministry is doing something about it. Regarding the drugs, these are drugs that, at least cidofovir and benzidofovir, these are drugs that we have been using to manage CMV, so they should be available in the country. I'm not so sure about the availability of tecovirimat at the moment. That's something, again, we'll need to check. But again, remember, it's only a very small proportion of patients who will need antivirals. The vast majority, and I want to believe more than 95%, will only require symptomatic care.
Yeah, thank you for that. So there's a question here about the lesions. I think you had covered it in the presentation, but maybe for emphasis, someone is asking, do the lesions clear completely or do they cause scarring?
I think it depends on the extent of the lesions. If it's maybe 1, 2, 3 lesions and it's not a severe infection, it's possible for it to heal completely without leaving a lot of residual scarring. But if it's a severe illness with skin loss, then definitely scarring is one of the complications that you will get.
So this is also, I think, a bit of repetition because they're asking about older individuals who are over 50 years. So they're asking what type of vaccine should they receive? Is it a replicating vaccine? Is it minimally replicating or non-replicating? Maybe you can just clarify on the type of vaccine that you had mentioned in the presentation.
I think what we said, the general population can receive any of the 3 vaccines. If the person receiving the vaccine is either a child, less than 8, pregnant or breastfeeding women, or immunocompromised, then for that particular group, then the recommended vaccine is the non-replicating one. So I think if you're older than 50 and you do not have any of the above mentioned complications, should be able to receive any of the vaccines.
Thank you. So I'm just skipping a few questions because I think there are repetitions. So going to the bottom, there's an interesting question here, maybe Sylvester. It's regarding IPC. So someone is asking about body handling. Does it include dead bodies, both human and animals? Is there any special measure? Like, did you come across anything?
No, basically,
Go ahead, yeah.
so basically, body handling, whatever it's the CDC and WHO have been explaining more about is about the human body handling. So on the animal body handling, because basically those are where the infection are basically found. But basically in the hospital setup, we're just working on the human body handling. I don't know. I don't think if there is anywhere we normally handle the dead animals, but basically public health will guide us on how do we handle now when it comes to animal body. Thank you.
Okay. Let's see. Thank you. So the next question is someone is asking about immunocompromised patients. So they're asking, how about patients who are immunocompromised, like CKD, diabetes? Are they also highly at risk for Mpox? Is their risk greater than for other patients? That's to Dr. Nyukuri.
So immunocompromised patients are at an increased risk of severe illness. And by immunocompromised here, I think when you're talking about immunocompromised, we should also realize that it's not always the same. So someone who has, let's say, hematological malignancy, someone who has advanced HIV, has a greater risk of severe illness as compared to someone who has HIV that is well controlled, or someone who just has CKD without any other complications. So I think here what we need to do is to assess each patient as an individual and basically look at the net state of immunosuppression. So you have to take into consideration the illness that they have, if they are taking any immunosuppressive drugs, and so on. And if you feel that their net state of immunosuppression is high, then this is a patient who is at high risk.
Okay, thanks. The next question is someone is asking for clarification, I think, on the duration of infectiousness. So they're asking, when is a monkeypox infected person no longer contagious?
So a patient is no longer infectious after all the scabs have fallen off and the lesions have started to heal. And this takes around 21 days, give or take.
Okay, thanks. So the next is on IPC. This is to you, Sylvester. Is eye protection needed based on the fact that it also affects the eye area?
So
yeah.
So basically, we don't need any special eye protection because the guidelines that we have are just for contact and respiratory mask. Actually, surgical mask. Put a clarification, it's just a surgical mask and gloves. So the eye protection is not required at this point. Thank you.
So, there's a question here, Dr. Nyukuri. They're asking if there's a different vaccine for patients who have HIV and have with zero viral load. Are there special measures for HIV positive, or it's just the same vaccines?
I think that's a great question, and there's something that we need to clarify. So for patients who have HIV, they are virally suppressed and with good CD4 count. Their risk is not that much different from a non-patient who does not have HIV. Because they are immune competent. So I don't think they should be approached any different from a non-HIV infected patient. However, for patients who have HIV and who have who have advanced HIV, then we know they are at risk of severe illness. And in this group of patients, we don't want to use the replicating or even the minimally replicating vaccine. So in that group of patients, then you should use the non-replicating vaccine.
Thank you. So there's a question here on IPC. Someone is asking, what do we do about sphygmomanometer cuffs, the BP machine cuffs? That's to Sylvester.
So basically, the beep machine cuffs, what you do is just you disinfect using 70% alcohol-based. That is basically surgical spirit, ethanol spirit. That is the spirit that is available. The 70%. There is no special antiseptic that is required on that. Thank you.
The next question is also yours. I think you had mentioned something to this effect. So there's a question here. In control measures, handle the situation where it is. I think you had said the cases should be managed where they are detected. So does it mean the person cannot be taken to a health facility based on the level of services required?
Basically,
Basically,
not really, because you don't need to manage the patient at home. This is whereby we have the anxiety, the panic, and also we end up managing a patient wrongly. And basically, we may not even now be managing Mpox. We'll be managing something which is very different. So the patient should be taken to the hospital because the doctor talked about the suspected case, the contact case, the confirmed case. So all those ones are only done in the hospital. So when the patient gets to the hospital, triage is done, and the patient undergoes all the processes that are required. Then now you don't move that patient from that hospital to the next hospital. Just manage that patient in that healthcare facility. Thank you.
Thank you. So I think when I look at the questions, I see most of the things were covered in the presentations. So I think we are about 15 minutes over time. Maybe I'll just give Sylvester and then Dr. Nyukuri a chance to give us their parting shot before we wind up the webinar. So maybe starting with Dr. Nyukuri and then Sylvester.
I think for me, as Dr. Lois has said, Mpox should not prevent us from taking care of our patients. We should not stigmatize patients who present to our facilities with a rash. We should use our clinical knowledge. Actually, these other illnesses, the herpes, chicken pox, and so on, are much more common, and you are much more likely to encounter them than Mpox. So put in place your APC measures. Don't stigmatize the patients, take care of them. Let's not have a similar situation as we did during the COVID pandemic, where other illnesses actually did account for the majority of deaths as compared to the COVID itself. Let's not have that situation repeat itself with Mpox. And we should always strive to keep ourselves updated. This is only an introduction to Mpox. There are materials out there for you to go out, read, be updated. We have new knowledge and new research being carried out. Let's be on top of the illness. Thank you.
To you, Sylvester. Let me just.
Okay, so the way Dr. Nkuri has just said, let's avoid panic and manage our patients the right way. Let's not just manage our patients with the symptoms, just a single rash or two rashes in the body, at our homes and everywhere, or even at our different health facilities, isolating the patient for no good reason. Let's just follow the IPC measures. They are all over. There is no special IPC measure or special case that is required in management of Mpox. So when we do the IPC measures, that is now the standard precautions, and when we just identify a case, confirmed case, we just put them in the contact precautions and then the droplet precautions. That will be all. And also I'll just highlight something small on the antibiotic use. Let's not start all of the patients on antibiotic, because now we will end up, because Dr. Nyakuri explained very well that when you're using antibiotics for special cases, when necessary. So just don't put all the patients on antibiotic. Any patient you see with a rash and antibiotic, because now you'll end up having the patient with the multi-drug resistant organisms, which will now be another case in management of Mpox. So all in all, thank you so much, and let's read more and more. Thank you.
Thank you, Sylvester. So I'll just read a comment from Dr. Lois regarding HIV-infected patients, because sometimes they can panic because they're immunosuppressed and they feel they're at higher risk. But what she says is that although many people with HIV have had Mpox, most of them were significantly immunosuppressed with low CD4 counts. With patients who are on ART with good viral control, their risk approaches that of the HIV-negative populations. Dr. Anne-Marie has also been on the panel with us. I don't know if you want to comment about tomorrow's presentation, which will cover children. Okay, I don't know if Dr. Anne-Marie can hear me, but you can see the flyer on your screen. There's a team from South Africa which is presenting their experience on the management of Mpox in children at 7 p.m. So I hope you'll be able to join us. So thank you very much for joining us. I think the messages have been passed.
Hi, Phoebe. Can you hear me?
Hi, Anne-Marie. Yes, I can hear you. Go ahead.
Yes, so there's a presentation tomorrow. A team from South Africa will be presenting their experience in children. My comment was around the rashes, and I saw a question about that. Somebody asking about the differentials. So they were very well covered by Dr. Nyukuri, and the two he highlighted is varicella or chickenpox and measles. So the rash of varicella tends to be vesicular, meaning you see blisters that are fluid filled before they become umbilicated, and it's what we call a centripetal rash. So it starts on the body before going onto the limbs, and it does not go to the palms and soles, unlike monkeypox. And then the rash of measles, if you just remember, what we've learned from undergrad, it tends to start around the crown, behind the ears, so coming from the head and then going down to the rest of the body, and it's maculopapular. So redness with erythema, flat lesions, and a few papules, yeah? So not quite looking like the monkeypox. I do agree those are differentials. Somebody there had asked about possibility of molluscum contagiosum. You do get molluscum lesions in children, but the child will be well. There's no fever, there's no pharyngitis. And if it is extensive, that only happens in somebody who's immunosuppressed, yeah? So that was just my one comment around the rashes, but thank you for a great presentation.
Thank you, Anne-Marie. So I hope you'll join us tomorrow for the presentation at 8 p.m. At 7 p.m. on the pediatric aspects. So thank you so much for joining us. Enjoy your day. Bye.